Okay, good afternoon everyone. Today we will be discussing about chemotherapy of tuberculosis, that is anti-tubercular drugs. So what do you mean by chemotherapy? Like, what do you have an idea about tuberculosis? Anyone? Mm-hmm. Okay. Okay, it's a chronic infectious disease caused by Mycobacterium tuberculosis. Okay. So since it is a chronic disease, then the lesion of the TB, the lesion of the TB is fibrotic and drug penetration in it's an issue over there. Okay. So the cell wall of this Mycobacterium tuberculosis consists of mycolic acid. What is the use of anti-tubercular drugs? Either it kills the bacteria or it the reduction of the growth of the bacteria. Okay. So here I'll explain about the cell, like Mycobacterium tuberculosis cell. This is a cell. Okay. Let's take an example. So the first thing is there is some reactive. This is a normal mechanism of the inside going. Okay, like normal mechanism is going inside the cell. So I'll explain like how does the drug act over here. Okay, so the first thing is there are some reactive spaces, so which is responsible for multiplication, which is like might support for binary multiplication of the cell. So these two are the drugs. Pretonamide and delamanid are the drugs which will just take part in the reactive spaces, so that like you understood, right? The second thing is DNA guidase inhibitors. So the first drug is levofloxacin, second drug is moxifloxacin, third drug is gatifloxacin. So these drugs act as a DNA guidase inhibitors. Okay. So the third thing is RNA polymerase inhibitors. RNA polymerase inhibitors, rifampin, which is also known as rifampicin, rifabutin, and rifapentine. These drugs act as a RNA polymerase inhibitors. Okay. The fourth thing is which affects the ribosomal activity. So streptomycin, kanamycin, amikacin, and linezolid, these drugs affect ribosomal activity of the cell. Okay. So the fifth one is which inhibits the ATP synthesis. Like as we know, ADP is transferred to ATP, and energy. It's an energy dependent. Like the cell needs energy, right? So this drug inhibits the ATP synthesis. That is beta-culin. Okay. So the last one, let's take an example. This is a cell wall, like cell wall, which consists of mycolic acid, and these are the drugs which are the cell wall synthesis inhibitors: isoniazid, cycloserine, ethambutol, ethinomide, and prothionamide. Okay. So this is the mechanism. Now I'll come to the drugs. The first line drugs is I'll just explain about the first line drugs over here. The first line drug is the first one is isoniazid, which is in oral as well as IM form, intramuscular, which is a prodrug, and the tablet, we'll see in the micromedics and all, the tablets is 50 mg, 100 mg, 300 mg, and injectables is found as 100 mg per ml. Sorry, and oral syrup is 50 mg per ml. So in the 6-month regimen, which is in the DOT therapy, the oral and IM. There is 5 mg per kg per dose. Usual dose is 300 mg OD, and in oral IM intramuscular 15 mg per kg per dose. The usual dose is 900 mg once, twice, and thrice weekly. Okay. So let's come to the pharmacokinetics. The absorption is oral and intramuscular. It is rapid and complete, and in distribution all body tissues and fluids including CSF. It is widely distributed in all the body tissues and fluids including the CSF, cerebrospinal fluid, and protein binding is 10 to 15%. It is metabolized in liver, and excretion is through urine, 75%, unchanged form, and feces and saliva. So peak plasma time is 1 to 2 hours. And half-life is 30 to 100 minutes in fast acetylators, okay, and 2 to 5 hours in slow acetylators. The side effects includes hepatotoxicity, which increases the LFTs levels in the lab reports, and sideroblastic anemia, systemic lupus erythematosus, and rashes is seen. Okay, these are the ADRs. So the second drug is for easy process. You can remember this for the first line drugs, HRZES. Okay, so the second drug is rifampicin, or we can call it rifampin. which is available in oral and IV form. Also the capsule it's 150 mg, 300 mg, and injectable powder will get 600 mg. Okay, so the dose is 10 mg per kg per day per oral, and 10 mg per kg per oral twice weekly, not to exceed 600 mg per day. Okay, so the coming to the pharmacokinetics, onset of action is approximately 24 hours, and it is absorbed orally, well absorbed, and distributed highly. So distribution is highly lipophilic, crosses the blood-brain barrier. Protein binding is 80%. It is metabolized in the liver. Excretion is through feces and urine. Mostly it's through feces, and secondary it's through urine. So the T half-life of the adults is 2 to 3 hours, and children is 1 to 4 hours. And peak plasma time is approximately 2 hours. The side effects includes hepatotoxicity and orange-red urine. Orange-red urine, mostly it is found in the women, and in the hospital and setup and all, if you'll come to know that some people have been administered this drug, so you need to check for especially in the women, you need to check if there is some orange-red urine or not in the patients. So the third one is pyrazinamide, which is found in the oral form, 500 mg. So in HIV negative patients, the TB treatment daily dose is 15 to 30 mg every day, not to exceed 2 gram. Okay, and TB for like HIV positive, this is for the normal people, and for the HIV positive people, it's 20 to 40 mg per kg per dose, not to exceed 2 gram. Okay. And coming to pharmacokinetics, absorption is well absorbed. The drug is well absorbed in the body, and distribution is widely distributed. Protein binding is 50%, and it is metabolized in the liver. T half-life is 9 to 10 hours. Peak plasma time is 2 hours, and it is excreted in urine as mostly through the unchanged form, in a unchanged form. So the side effects is dose-dependent hepatotoxicity and hyperuricemia. Only pyrazinamide and ethambutol has the side effect of hyperuricemia. Okay, it is important, so you please remember it. And the fourth drug is ethambutol, which is only found in the oral form, 100 mg, 400 mg. So I'll tell you about the dose over here. The initial treatment will use 15 mg per kg per day, every day. And prior the TB treatment, like it means the first, if the patient comes, you'll do a differential diagnosis, right? So in the differential diagnosis, once the doctor suspects that the patient is having TB, so prior the treatment of the TB, like proper treatment, they will start with the 25 mg. So after 60 days, after patient is properly diagnosed with the TB, then the doctor starts with the 15 mg dose. Okay, so this is a drug, like mostly all the drugs are dependent on the weight, and so I'll explain for this ethambutol. In daily 40 to 55 kg, it is used 800 mg. To 56 to 75, 1.2 gram. More than 75 kg, 1.6 gram. And for twice weekly, this is for daily use, and this is for twice weekly, 40 to 50. I know this is difficult to remember, but this is very important in the hospital setup. So twice weekly, 40 to 55 kg, 2 gram, 56 to 75 kg, 2.8 gram, more than 75 kg, 4 gram. And for thrice weekly, 40 to 50 kg, 1.2 gram, 56 to 75 kg, 2 gram, and more than 75 kg, it's 2.4 gram. Okay. So coming to the pharmacokinetics, it is absorbed, well absorbed, and approximately 80%. The distribution is widely distributed throughout the body. The protein binding is 20 to 30%, metabolized in the liver. Excretion is through urine, 50%, and feces, as well as saliva is there. And T half-life is 2.5 to 3.6 hours. In case of end-stage renal disease, the T half-life is 7 to 15 hours. This is also quite important. And the peak plasma time is 2 to 4 hours. So the side effect is optic neuritis, the color vision, the red and green color vision, optic neuritis is seen, and hyperuricemia. As I told, only in the pyrazinamide and ethambutol there is a hyperuricemia. So the last drug is streptomycin, which is in IV and IM form. The powder for injection is 1 gram. For TB, daily dose is 15 not to exceed more than 1 gram per day. And for twice weekly, it's 25 to 30 per kg, mg per kg. So pharmacokinetics, coming to pharmacokinetics, absorption is well absorbed. The drug is well absorbed in intramuscular and poorly absorbed in oral form. It's streptomycin, and widely distributed. The T half life is approximately 2 to 4.7 hours. The peak plasma time is 1 to 2 hours and is excreted through urine. Okay, and side effects is nephrotoxicity and neurotoxicity. As well as there is a hypersensitivity. Yeah, that's it. And there is a drug name, like combination drug name. I don't know if you will get in this hospital or not, because in the formulary it's not there. So this is a combination of rifampicin 150 mg, okay, rifampicin 150 mg, isoniazid 75 mg, pyrazinamide 400 mg, and ethambutol hydrochloride 275 mg. So this is a drug that has been using in the hospital setup. I don't know about our hospital though. It's there. Oh, okay. Yeah, that's it. I'll say the second line drugs. The second line drugs are fluoroquinolones. In fluoroquinolones, there is ofloxacin, levofloxacin, moxifloxacin, and ciprofloxacin. The other oral drugs are ethianamide, prothionamide. As I said, these are the Axan. You'll come to know when to use these things. And ethianamide, prothionamide, cycloserine, para-amino salicylic acid, and rifampicin. And injectables are kanamycin, amikacin, and capromycin. Thank you.